All right. Good evening, everybody. I'm Aaron Fox with KSB Community Wellness. So thanks, everyone, for joining us tonight. We got a great program, Understanding Hereditary Cancer with Cami Doubet. So with no further ado, I'll pass it right on. We can get right into tonight's program. Thanks, Cami.
Hi. Thank you. Thanks, Aaron, very much for the introduction. My name is Cami Doubet. Like Aaron said, I'm a genetics nurse practitioner at Illinois CancerCare. I work down here in the Peoria office, but as you guys probably know, we are currently now up in the Dixon area with a new clinic in the last year, and we have several providers that are up there for the oncology clinic. So part of our oncology program has really, over the last approximately 10 years, really taken off, and we have expanded into a larger genetics program. And so I help to coordinate that program as one of the genetics providers. So I just want to talk to you a little bit about that program tonight, hopefully give you some information about what cancer genetics is really all about, kind of the role that genetics plays in the world of cancer today, and just give some real basic information about cancer genetics to start with, and then how you can access resources in your own community if you are interested in doing so. So we'll move ahead with our slide program. Aaron's going to help me out with slide presentation tonight. So this is just a list of our current genetic team members. This program has grown significantly over the last several years. It started out initially with just one physician about 10 years ago. And in that 10 years, not only has our program grown, but the world of genetics has really grown significantly. So I've been with the program for about 5 years. And just in that amount of time, we've seen a significant change. So I was one of 2 nurse practitioners at that point in time. And as you can see, we've expanded significantly. We have 3 genetic physicians that work with our program now, including Dr. Fishkin, who is our lead physician. And then we have several nurse practitioners as well, and medical assistants that are kind of our right and left arms. So they're instrumental, but we have providers basically in all of the communities that we practice in today. So there is no lack of access. We have resources available in a variety of ways, including just like I'm coming to you guys tonight with telemedicine. We've really been able to expand our availability to communities by doing a lot of our genetics visits either online or with even telephone visits. So it makes it much nicer for those of you who live outside of the immediate Peoria area to be able to access resources locally and still provide services that we can offer here in Peoria as well. I'll go to the next slide. So one of the primary roles of our genetics clinic is to really help individuals and families to understand if there is a possibility of there being some sort of a hereditary predisposition for cancer due to a specific genetic mutation. And so when we are talking to either family members or patients in the clinic, many times patients want to know, why did I get this cancer? Where did this come from? And other patients come to see us simply because they have a family history of cancer and they're concerned and they want to know if they may be at some increased risk based on their family history. And so there are a couple of things that we evaluate. And one of the things that we do look for basically is an inherited abnormality that could be passed on from family members in the DNA. And those typically are going to be passed from parents to children. And we'll talk a little bit more specifically about that in just a few minutes. But we are looking basically at the DNA. So we are looking for what we call a germline mutation that would be something that could be inherited. And it is in every cell of your body. And that is something that the genetic providers do a health assessment when they talk to individuals in the clinic about their family history to determine if there seems to be some increased risk based on that cancer history in an individual's family. There are other forms of genetic testing that can occur in the world of oncology today. It's actually taken a huge role in terms of offering newer, more targeted treatments available for individuals. There can be genetic testing performed on cancer cells themselves now, as opposed to just doing it on your DNA. So they're very different. Those are 2 different kinds of testing. As a genetics provider, I do not perform testing on tumor tissue. We call that somatic testing. However, our physicians and oncologists order those tests when it seems appropriate for individuals who are affected with cancer already. When we have someone who already has a diagnosis of a cancer, oftentimes many of the diseases that we treat today have different treatment options available, and some of that does depend on the genetic makeup of a specific type of cancer. Next slide, please. So let's talk just basic DNA. What does that mean? What is DNA? Why do we care about it? What difference does it make? So we are all born with the same 23 pairs of chromosomes. Chromosomes are where all of our genetic material is basically carried, and we inherit one chromosome from each parent on all 23 pairs of those chromosomes. When you inherit one chromosome from mom and one chromosome from dad, we call that an autosomal dominant pattern of inheritance. That means that you get 50-50 chance of inheriting anything that mom or dad may have in their DNA, whether it be good or bad. That could include your eye color, your hair color, your skin tone, but it also carries implications for diseases. And so there may be some inherited risk based on some of the disease patterns in families. That is including specific genes, and those are the genes are carried through the DNA. In any situation, any child who is born to an individual that carries a genetic mutation has a 50% chance for inheriting the gene that has the mutation on it. They have an equal 50% chance of inheriting the gene from the other parent who doesn't have the DNA mutation. So it's possible that you can inherit the normal DNA, or you can inherit a gene mutation from the parent that's affected. It's also possible to actually inherit more than one mutation. And believe it or not, we have multiple families that I actually follow who do have multiple genetic mutations in their families. These individuals can carry increased risk for more than one type of cancer. And so we do follow them closely in our high-risk genetics clinic. It's less common for that to happen, obviously, but if someone has two parents, each affected by a DNA mutation, then that means that we would each have a 25% risk of actually inheriting both the mutations from both mom and dad. A little bit more complicated, but it does happen, and we do see that occasionally. Fortunately, it is not a common scenario. Next slide, please. So this is just a picture of DNA. So the DNA is basically two strands of genetic material that are linked by different amino acids. And you can see the different amino acids that are causing, or that are kind of linking the two strands of DNA together. That's a little bit more sci-fi, but that's really what the rest of us look like. If you stretched out those strands of DNA that we all have in our body, they would literally cover miles. And so there's a lot of genetic material all rolled up inside every cell that we have, which is kind of fun, a little nerdy, I know, but that's kind of what we get excited about in the world of genetics. So next slide, please. So let's talk about those germline mutations that I mentioned. What is a germline mutation? Where does that come from? So any kind of a gene that changes in a body's reproductive cell, whether it be an egg or a sperm, becomes incorporated into the DNA of every cell in the body of the offspring. So if a germline mutation is passed on from parents to offspring, you have the copy of that gene that does have the abnormality. There are germline genetic testings that require basically a sample of any kind of DNA tissue that we can get. And in our situation, you can use blood, you can use saliva, hair, you can use the swab of the inside of your cheek, or you can do skin tissues. And we usually will collect either a blood or a saliva sample, although we do send some folks off to have skin tissue samples for a variety of reasons as well. All of them are equally reliable and accurate. It just is dependent upon exactly what we're trying to obtain and why we're obtaining it. Next slide, please. So these somatic mutations that I mentioned are really mutations that can occur again after conception, and they can occur in any tissue except for those cells that are the product of conception, both egg and sperm tissue, and they cannot be passed on to children. So these are alterations that occur in an individual that ultimately do not always, but can cause cancer and other diseases. So when we are evaluating those individuals already affected by cancers, we will sometimes look at those cancer tissues to see if they do have genetic mutations in those tumor tissues. Those tumor tissues can also then be sometimes a little bit of a clue if there is a potential for a germline mutation as well. Not always, because the cancer cells tend to mutate on their own and create new mutations. That doesn't mean that those are all inherited, though. Next slide, please. So how do you come to see a genetic professional at our clinic? So there's a variety of ways. Again, if someone comes to our office as a new cancer patient with a new cancer diagnosis, they would meet with one of our medical oncologists. Oftentimes, the medical oncologists will do a very thorough family history when they meet with that individual for the first time. And if there is anything in that family that would seem suspicious for there to be an inherited tendency for cancers, oftentimes the oncologist will make a referral for those individuals to speak with one of us in the genetics clinic. They may sometimes even go ahead and order the test themselves, not always, but they may. And then oftentimes they will have you do a follow-up with one of us as the genetic professionals to try to explain the test results and talk about what that might mean for you as an individual already diagnosed with a cancer. Other patients can also refer themselves due to just a family history of cancer. So this is not just for individuals who have already been affected by cancer. Some of these individuals are people who maybe have had a parent or a sibling who was already diagnosed and found out that they had a genetic mutation. And that does happen when we see those individuals. They already know that they have a 50% chance of carrying a genetic mutation and that may have inherited risk for cancer. Other individuals just know that they have a cancer history in their family. They've heard about genetics. They know enough to know that there could be a potential for a genetic mutation that might create risk for them. And so they come to see us as just a self-referral. And those individuals will oftentimes have more information about their family that we can then just explore and talk about and determine if that at that point in time whether they would qualify for doing any genetic testing. Next slide, please. So there are some specific criteria that we look at to determine if an individual really does need to be tested or if they qualify for genetic testing. There's lots of different gene mutations out there, lots and lots of gene mutations. We certainly don't know about all gene mutations that exist today. We do know that certain types of cancers and certain types of even family scenarios carry some increased risk and seem more likely to have an inherited genetic mutation in those individuals or those families. For example, there is a gene that does carry a significant risk for women who are affected by it to develop either breast or ovarian cancers. That gene is called the BRCA gene or BRCA. And in that arena, we see individuals who may have a strong family history of breast cancer. We may see a history of ovarian cancer in those families. There may be a variety of other cancers, even including pancreatic or melanoma cancers in those individuals. And so those are families where we know that there could be increased risk for this BRCA gene. And so we would then determine whether that individual meets the specific criteria. And again, there are very specific national guidelines. There are lots of different governing bodies that determine kind of who really meets criteria based on what we consider to be the most significant risk factors for individual diseases. Other cancers do not always have such clear-cut guidelines. So some of those that we see the most commonly for genetic testing include breast cancer, as well as colon cancer, ovarian cancers, sometimes prostate cancers in men, because there can be genetic mutations linked to those. So those are some of the more common cancers that we get referrals for. Other diseases may not have quite as clear-cut referrals or as clear-cut guidelines for that reason. And so those are individuals that we do spend some time just trying to talk a little bit more about to try to help determine if there is enough cancer history in that family to substantiate doing testing. And there's some reasons that we don't want to over-test, but we certainly want to be able to help evaluate families that may have concerns or may have legitimate risk for increased risk for cancers as well. Next slide, please. So what does make a person look suspicious for a genetic mutation? So as I said, certain types of cancers can, and that does include certain cancers that are more rare. The more rare a cancer is, the more suspicious it may seem for there to be a genetic mutation. So an early age of onset of cancer also, usually anything under 50 is considered to be young. It gets younger all the time for those of us who are over that, but it does mean that those individuals have a little bit more likelihood for carrying a type of genetic mutation. Another risk factor includes bilateral or two organs that are a pair of organs, if you will. So breast cancer, for example, that happens in a woman who has both breasts affected, or if an individual has kidney cancer in both kidneys. Those are far less common scenarios, and so those do carry some increased risk and concern for there being a genetic mutation in those types of individuals. If multiple family members have been affected with the same type of cancer or similar cancers, one example would be in the world again of colon cancer. So colon cancer is a disease, it's a fairly common disease, but some families do have a significant risk for it based on certain genetic mutations, and you will oftentimes see multiple family members affected, and oftentimes those individuals will be affected at younger than average ages. There are also some specific types of certain cancers that can also be associated with greater risk for genetic mutations. One example, again, in the breast cancer arena, we have lots of different kinds of breast cancer. Not all breast cancers are created equal. And breast cancer is one of the diseases we do probably the most testing for. In that situation, a woman who has what we call a triple negative breast cancer has a little bit of an increased risk for having an associated genetic mutation. So younger women diagnosed with triple negative breast cancer would always be referred for genetic evaluation. Next slide, please. So what's the procedure at Illinois CancerCare when we do testing? And we're not really unlike a lot of facilities, but each individual healthcare facility may have a little bit different process in place. As I said, the genetic arena has really exploded over the last even 5 to 10 years. And so there are new genetic providers kind of popping up all over the country. And some are in solo practice by themselves, and others are in large research facilities or university facilities, or they are in community clinics like ours. So in our particular facility, we do have providers that meet with a patient to obtain that comprehensive cancer and health history about the family and about that individual's cancer as well. There are, again, certain characteristics to a specific cancer that will make it a little bit more suspicious for a genetic mutation. When you meet with that individual genetic provider, then they would make a determination whether you, number one, qualify for genetic testing based on your specific scenario. Do you have a specific cancer that appears to have the suspicious characteristics for a genetic mutation? Or do you have a family history that appears to be suspicious for the genetic mutations? And if so, then they would have a conversation about what that means for you as an individual and explain sort of what the implications for that could be. So, again, we would obtain a sample of DNA, and that usually involves either a blood draw. If you are in one of our facilities, that is by far the easiest and most reliable way to get a good DNA sample, and it's quick and easy right there in the clinic. You can also have a saliva sample obtained, as I mentioned before. Those actually can be sent to an individual's home, which is kind of cool because people can actually be, in their own kitchen and do a saliva sample. Those kits are sent out in the mail. They come straight to your home. You literally pick them up out of the mailbox. Excuse me. And then you would be able to collect the saliva sample and then send it right back in the U.S. Postal Service. So those are sent out to a large national genetic laboratory. We do not run the genetic labs in our office because it is a special type of lab equipment that's required for that. And so there are several large national genetic labs that really run the majority of genetic testing. We use a laboratory in California called Invitae. Invitae has a lot of resources available. They're a large reputable national lab, and so they also work with us very nicely. Usually the specimens are sent out same day or the very next day, but have to be sent within 72 hours. And typically we will get results back within 2 to 3 weeks. Once we have those results back, then one of our medical assistants will usually reach out to individual patients and get them set up to come back and talk with the healthcare provider that ordered that testing for them. Next slide, please. Patients do have to have a consent form signed for genetic testing, and that is because there are some implications for the testing that you really want to be aware of before you make a decision about genetic testing. There is a federal law called the GINA Act. It stands for Genetic Information Non-Discrimination Act, that was actually passed in 2008. And it was passed with the intention of protecting individuals who carry a genetic mutation from any discrimination for either health insurance or for long-term kinds of insurances. Or I'm sorry, for employment purposes. It doesn't apply to life insurance or long-term kinds of insurances. And so individuals who are diagnosed with a genetic mutation need to be aware before they actually have their testing that there could be implications for life insurance or for long-term insurance. And so it doesn't affect any insurance that's currently in place, but it could have implications for future insurances down the road. Next slide, please. As far as test results, there are really 3 individual test results that can be returned on every gene that we actually look at. And so in some situations, we test for genes that are indicated based on an individual or a family history of cancer. And so if an individual has a new cancer diagnosis, we certainly will look at the genes that we know to be associated with that cancer, but we also will still include the information that we have about their family. So most of the time, individuals have what we call a panel genetic test, meaning that there's a group of genes that they call a panel associated with either one or specific types of cancers. And we will test that patient for all of the genes that we know it to be associated with those cancers. There could be anywhere from a half a dozen genes to up to 100 genes. And so depending on each individual's family history and cancer history, there will be some will have a far more limited number of genes and others will have a much greater number of genes. Not all cancers are genetic. And so this is really important information because it's really important to understand that when an individual has a cancer diagnosis, most people want to figure out where it came from or find out what the cause for this was. And really only in the grand scheme of things, about 10 to 15% of individuals affected with cancer have a known genetic mutation that is correlated with their particular cancer. So not all cancers have a genetic background that we can actually link to their specific cancer. And we do talk about that when we go through these results. Next slide, please. So again, there are 3 possible test results for each gene that are tested. You can get a positive result that says, yes, you do carry a genetic mutation that does carry increased risk for cancer. Does not mean you're going to get cancer. It does mean that you may have increased risk. And with that information, then we can then be more proactive about trying to do things that will reduce risk for those cancers. You can get a completely negative test result that says, of the genes that we're testing, there isn't anything that we see that's abnormal. So we don't have any reason to suspect that that cancer had anything to do with any particular genetic mutation. That does not always mean that there's not increased risk in a family. It just means we don't have a specific gene that we can pinpoint for that reason. And then the third result is something called a variant of uncertain significance. And this is everyone's least favorite because the variant means that there's something in a gene that doesn't look totally normal. But the reality is that we don't have enough data on that specific change to know if it actually carries any increased risk for cancers or not. Most of the time, those will eventually gather enough data to be reclassified. And about 90% of the time, they get reclassified to be benign. However, in about 10% of the situations, they do get upgraded to be something that we call a pathogenic mutation, meaning we find out that there is enough information to correlate it with increased risk for cancers. Next slide, please. So what kinds of cancers have genetic mutations? I've talked about some of those already, but one of the more common cancers that we see for women is breast cancer. Breast cancer is the most common cancer for women in the United States. 1 out of 8 women in the United States get that cancer. And these are cancers that are so common that oftentimes women assume that there must be a genetic connection, especially if they have family history. The reality is 1 out of 8 women in the United States get breast cancer today, and that's assuming that you live to be in your 80s, not at 30 or 40 or 50 years old. However, of all the women that are affected with breast cancers, only about 10% of them actually have a known genetic mutation. So the vast majority of breast cancers are still not genetic, even though they may still have some family history of cancers. Next slide, please. Prostate cancer is the most common cancer for men in the United States. Somewhere between 15 to 20% of men in the United States will develop prostate cancer if they live long enough. Again, it's a disease that you see more commonly in older men, but we do sometimes find it in men who are diagnosed as early as in their late 40s, early 50s. Again, these younger men are going to be a little bit more suspicious for carrying some type of a genetic mutation. The BRCA genes that I mentioned previously that are known to be associated with risk for breast and ovarian cancers in women also do carry increased risk for prostate cancer. And so when a man finds out that he has a genetic mutation that could potentially increase risk for prostate cancers, we start doing screenings at a younger age. We also would look at the other family members that may have increased risk for prostate cancers due to genetic mutations as well. And then we would talk about how to move forward to counsel those individuals. Next slide, please. Other cancers that we know that do have some association with genetic mutations include some that, again, are more rare cancers, ovarian cancer being one that only affects less than 2% of all women in the United States. Pancreatic cancer, another one, very rare cancer, still affects less than 1 to 2% of individuals in the United States. And again, the more rare the cancer, the more common we may see some increased risk for a genetic mutation. Other more common cancers, though, colon cancer. Colon cancer is the third most common cancer in the United States for both men and women. It now affects almost 5% of the population, unfortunately. And for that reason, they do have increased screening guidelines recommended for anybody, whether they have a family history or not, and whether they have a genetic mutation or not. Kidney cancer also is another one that can have some genetic mutations associated with it. Not all of these are as well understood. Some have far more information and data than others, but we are learning a lot more about them as we go. And so these are genes that, or these are cancers that we do recognize warrant oftentimes further additional genetic testing in these individuals. And when we do identify a genetic mutation, it allows us then to be more proactive with cancer screenings. So we can do earlier mammograms. We can start colonoscopies at a younger age. We can start those prostate exams for men at 40 or 45. These are ages that we wouldn't normally start those kinds of screenings. They can also offer additional other imaging sometimes for different kinds of cancers that might be harder to discern, particularly based on symptoms or physical exams. And even sometimes there could even be surgical implications for further risk reduction. Next slide, please. Benefits of genetic testing, again, proactive screening to reduce the risks. There can be reproductive implications as well. So for young people who are still in their childbearing years, there are options for them to consider doing pre-conception counseling, where they can consider their options for reducing risk for passing on genetic mutations to their future children if they would choose to do so. It does involve doing a little bit more fertility planning, but that is an option for individuals that are interested. Children of the mutation carriers may benefit from making different lifestyle choices. So younger individuals who don't have cancer but find out they're carrying a mutation and have increased risk can certainly make some different lifestyle choices. Things like healthy lifestyle, including diet and exercise, alcohol and tobacco, all have bearing on risk for cancers. And so that's good information for individuals to know early on. And then some mutations do carry the greatest risk for individuals that inherit copies from both parents. And so you have a condition called an autosomal recessive condition, meaning if someone has a child or is going to have a child and they know they carry a mutation, they may want to have their partner tested for that same mutation, because they know that if the child is born and has both copies of the genetic mutation from both parents, that child may have a significant risk for other significant health issues. And so again, it involves doing some counseling and testing either prior to having a child or when the children are very young prior to having any of those significant health issues. Next slide, please. So again, just kind of in a quick summary, there's a lot of pros and cons to doing some genetic testing and counseling, but in our arena, we really do feel like the pros definitely outweigh the cons, only being that sometimes there can be some anxiety associated with knowing about genetic mutations, but we really try to focus on the things that we can do to help reduce or minimize risk by having this information available to individuals even before they have a cancer diagnosis. If you have any interest in pursuing any kind of a genetic referral for yourself or someone in your family, if you have a family history of cancer that you just want to learn more about and get more information about, you are more than welcome to call our office. Our contact information is here on the last page, and Nicole and Rachel are our fabulous schedulers and genetic assistants that help us with all of the coordination of scheduling and making referrals. So please feel free to reach out to us at any point in time and let us know if you do have questions, or if you have interest in making an appointment with us. I think that's all I have. I could go on for a lot longer, but I don't want to overextend my welcome tonight. So thank you so much for allowing me to be with you tonight, and please feel free to give us a call. Have a great night.